Welcome everyone. This is Dr. Sharad Jaitly from New York. Thank you for watching, learning, and sharing on MuniMeterHealth.com, your favorite website, which is dedicated to teaching you and educating you on human heart care and as well as its illnesses. So we are on Facebook, as you know, and of course on YouTube. So the two, wherever you're following us, I appreciate your enthusiastic support and associating with us because now we have a growing tremendous interest across the globe with our knowledge that I want to spread for free to all of you. So once again, welcome again to MuniMeterHealth.com, your favorite website. Without any further ado, I'd like to delve into the matter of the heart. The state of the heart today is territorial blood supply to the heart walls. So here I'm going to be discussing this briefly. So what is the territorial blood supply and how does that affect the heart supply to the heart walls? Basically, you're already familiar with the heart walls. We know the heart walls, it's just like the four-chambered heart, but at the same time we need to know how the walls of the heart are being supplied. So that's what we're going to be discussing. Now here is your heart in this fashion, and that is your long axis view, if you will. And here is a short axis view, which I'm going to be drawing like in double circles. I hope I can draw the circles well. And then this is your apical view, where the heart looks like this, more or less. Okay, so here's your apical view, and this is your short axis view, and this is a long axis view. So basically you're looking at a heart in a three-dimensional fashion. That's the point I'm making, whether you're looking on an echo, an MRI, or a nuclear scan. So this is typically a nuclear scan view where one examines the heart in the following fashion. So this becomes your anterior wall. This becomes your apical wall. I'll write AP because just to distinguish. And this is your inferior wall. Now here, obviously, this becomes your anterior. This is your lateral. This is your inferior wall. And this happens to be a septal wall. Here is your septal. This is your apical. And this is your lateral wall, if you will. Okay? So having understood these various walls, let's try to understand what is supplying, which wall is being supplied by what. So understand that the anterior wall is supplied by LAD, almost up to the apex. Remember that, almost up to the apex. So we'll just make a note of this and say this is your LAD for reference. So green is LAD. Now the inferior wall is supplied by the RCA. I'm showing it in the blue, all the way up from base to the almost to the apex. So this becomes your RCA, that's the right coronary artery. So similarly, you have inferior wall here, which is being supplied by the RCA here. Whereas the anterior wall we just did was being supplied by anterior, and the septal, if you will, was being supplied by the LAD. Now, similarly, let's do the septal here as well. So we are completed almost up to the apex with in these fashion, and let's draw a different color. We'll choose a different color for our for the sake of it, for the circumflex. So how is the lateral wall being supplied? Lateral wall is being supplied by the left circumflex. Here's from almost apex. The circumflex runs almost to the apex. So does the tip of the RCA and the LAD, of course. So you'll see the apical supply is pretty much everywhere. By all the, you could say that typically all three arteries will come to the apex here. So let's draw this as well here, and that completes your reference point. So the left circ is shown in the purple. So green is LAD. You can see the anterior and apical, anterior and septal here, and then entire septum is supplied. Remember, the entire septum is supplied by LAD. RCA is the inferior wall, which is seen in the long axis view in this fashion. And then, of course, in short axis, it's a sufficient supply, if you will. So right from base to apex, and you can take several sections of these short axes and go almost to the apex where the cavity obviously will diminish. And you can take different cuts. And similarly, the circumflex, which is going around and supplying the lateral wall, and a little bit of lateral wall can be seen here as well. So anywhere where you see an ischemia, you will see a reversing of the defect. That means here, say for instance, there was a defect that was present during stress, and it reverses during resting time. Automatically you know that this is a reversible defect, say in this region, and therefore the anterior wall ischemia was present during stress, which is exercise-induced ischemia, and that's how we write a report in a nuclear session. And so that's typical of that territory. Likewise, you could say a lateral ischemia was present. Why? Because there was a reversible defect in the lateral wall, and that reversed fully. Now, if there's a fixed defect, then there are only two things. One, it could be an artifact, which is related to either an overlying, say, breast tissue wall or chest wall if the person is extremely muscular with a lot of pectoral muscles. Then anterior and lateral could be seen as fixed defects. Sometimes a diaphragmatic tissue can also cause a fixed defect because of the diaphragm being very high in those settings, especially if patients have huge bellies. So if they have a lot of adipose tissue in the abdomen, you'll see the diaphragm is pushed up, and this inferior wall, right, both in short axis as well as in the long axis view, will appear as a fixed defect. So that's one cause of fixed defect, that is the artifacts. They are fixed. The second cause, which is an important cause, is where you see a fixed defect because of a myocardial infarction. And that could be either because of an actual inferior infarct, like an inferior wall here, or an actual apical infarct, where this portion of the apex could be not reversing. In other words, stays fixed both in stress and rest. So you could see a fixed defect. How do you distinguish? Now the question is, how do you distinguish these fixed defects between an artifact and an infarct? Well, the answer is very clear. Remember, you're seeing everything in motion. So when you see in motion, you will see these walls coming in. In reversible ischemia, like I said, where there's reversible defects, you will see a wall motion abnormality where this wall will not come in as good, and also, of course, the defect will reverse. But if the defect is fixed, then how do you tell? Similarly, just like what I just gave you a clue with the reversible, you will see in the artifact, when the artifacts are present and you have a fixed defect, these walls will still move in because it's the artifact, and the walls will still continue to move in. Whereas if you have an infarct, these walls will not move in. In fact, they will only be akinetic or dyskinetic, if you will. So they will move out. So if there is a lateral wall fixed defect and the wall is moving out during the gated blood pool scanning, at that point you can infer that this is definitely an infarct and not a artifact. But if the wall is contracting well and is coming in during systole, or contracting well in concert, and the EF does not drop, then you know that the wall is this is because of a lateral and it's a fixed defect. You'll say that this is a lateral defect because of a attenuation or because of an artifact. Okay, so just quickly, I wanted to summarize these various territorial blood supplies with you here to the heart. And of course, we have talked about the reversible defects and irreversible defects. And the irreversible defects could be attenuation, which is artifacts, and infarct. And the only way you can distinguish them is by showing the wall motions abnormalities as well. So looking forward to seeing you again on my next presentation. Hope you enjoyed this one, where I briefly touched upon some nuclear aspects of various territorial blood supplies and talked to you about the various walls. And of course, now you're an expert on where the distribution of the walls, how the blood supply goes to different walls. Okay, and thank you for watching MuniMeterHealth.com. I appreciate your enthusiastic interest. Until then, Dr. Sharad Jaitly says so long.